Hello, everyone. So great to see you. Welcome. I want to welcome all of our faculty, trainees, students, friends, family members, everybody that's here and from our community to celebrate research. My name's Ebony Boulware. I'm the Dean of the Wake Forest University School of Medicine and the Chief Academic Officer for Advocate Health. And I'm so delighted to have you here as we focus on celebrating research, the beginning of an incredible month where we're going to be highlighting all that research offers to our communities. There's something really special about launching this, our second Celebrate Research Month, here at the Caladium. It's a place that's built around curiosity, discovery, and learning. And those same ideas are certainly at the heart of everything that we do in research, particularly here at the Wake Forest University School of Medicine. Research starts with a need, a question, a curiosity, something that we need to learn more about, something that we need an answer to. And when we pair that with collaboration, inquiry, dedication, and a staunch commitment to getting those answers, we get discoveries. Those discoveries lead to improvements in lives, in the way we do things, everywhere. So this is really the impetus for Celebrate Research. It's really a time for us to appreciate all the outstanding work that's happening in our research here at the Wake Forest University School of Medicine and across Advocate Health. And it really reflects our hope that we continue this critically important mission, that we continue through all the work that we do to impact the lives of millions. During this month, we're going to be shining a light on several different types of research. Research that's happening among individuals, with patients, with families, in clinics, and also in laboratories across the nation. We're going to be highlighting all the dedication and the excellence that happens in our research mission. None of this happens alone. It takes dedicated individuals. First, it takes people coming to us with questions and problems that need to be solved. Then it takes dedicated individuals who identify that as something worth really pursuing and interrogating and questioning and wondering, how can we do this? How can we address this problem? Once we have that, it's teams of individuals. It's never one individual that makes a great discovery. It's always teams of individuals that come together and do that. And that teamwork, that collaboration is so essential to how we get to those next stages of understanding. This month and tonight really reflects how we come together to honor that. And celebrating research is really about celebrating all of that, the progress that are made. Tonight, as we get started, it's really special to start off with pediatric research, because that's really where it all begins, the life course, how people are born, experience their lives, the multiple impacts that they have, the multiple influences and their outcomes along the way. That influences the way that they thrive from not just beginning, but all the way throughout an entire life. Also impacts not just the individual, but their families, the communities, the whole, broader population. And so for that, it's so important that we start here, and it's really exciting to do that. I'm so excited to beginning that focus. So first, I want to thank all of you for being here. I also want to thank the coordinators for this program. So many have contributed to it. Dr. Lynn Waganek, Dr. Christina Ferdui, Ari Ball, and a whole team of individuals who've come together to pull this together. This is really a year-long planning process, and we want to thank our leaders for doing that and everybody who's contributed. As we get started, I want to introduce Dr. Lindsay Thompson. It's truly fitting that we start off with her and the work of pediatrics. Dr. Lindsay Thompson is our Enterprise Academic Chair for Pediatrics. Her journey began with a focus on biomedical ethics at Brown University, followed by her medical training at Columbia and a master's in evaluative clinical sciences from Dartmouth. That foundation in ethics and clinical research has informed every step of her lengthy career. Before joining our one school, two campuses family, she spent over a decade at the University of Florida, where she led transformational work in health outcomes and translational research. Today, she holds the Weston M. Kelsey Professorship and is an elected member of the American Pediatric Society, one of the highest honors in her field. Her influence extends nationally as an editor for JAMA Pediatrics, and through her leadership with the American Board of Pediatrics, she's chaired committees focused on the future of physician certification and other areas. But beyond that, Dr. Thompson is a true clinical innovator who's really brought the rigor of research to her department and to her mission as a leader. So many vital initiatives have evolved under her leadership, and she has really helped our department grow and blossom by training and supporting and recruiting amazing faculty, and then, of course, training our outstanding students and residents and fellows. She joins us today to talk about a concept that's truly at the heart of her work. She's going to be talking about kids aren't little adults. So I'm looking forward to hearing about that, because my kids think they're little adults. I'm not sure about that. But thank you so much. We're really grateful for your time. And Dr. Thompson, welcome up.
Well, thank you all for being here. This really is an incredible event. And yes, I am a proud advocate of anything to do with children, children's health, and pediatric research. So I want you to indulge with me. So first, I want you to think back to your strongest feeling of joy. And now, please think back to your strongest time you felt scared. Chances are both of those happened when you were a child. Childhood is a magical time. It's a time when everything is impactful, more meaningful, and truthfully more fragile. While the physical cuts and bruises that we got as a child healed much faster than they do now as an adult, but the emotional pain we may have received as a child is so much more profound and enduring. And that's exactly why we need children's hospitals, and is also exactly why we need pediatric research. If we take care of children's experiences, their health, and their families too, we will make children stronger, and they in turn become healthier adults. When we think about medical care and health services research, many people assume that discoveries made in adults can just be scaled down for children, ostensibly to avoid exposing them to whatever we were testing. Smaller doses, smaller devices, smaller bodies. That's true. But that smallerness takes innovation, time, and dedication. In its simplest form, hospitals, children's hospitals, must have different kinds of everything. Different kinds of beds, isolates, open cribs, climber cribs, open beds, and rooms that are big enough for a parent or guardian to stay with them. You wouldn't want a child to be alone. And even we need different training mannequins. And yes, this is a real problem. We spent almost $80,000 in philanthropy money last year to have a state-of-the-art, much-needed simulator to look and act like a neonate. And this picture here, this is not a fashion statement. It's not even a pulse ox to measure oxygen. This is how we measure blood pressure in extremely low birth weight babies, where a small variation in their blood pressure can cause a stroke. And so this technology is not only smaller, but it also required adaptation to all the different machines and the extremely sensitive skin of a premature infant. And in addition to the equipment in healthcare, we want to make children-friendly experiences and places, areas where children can feel calmer and then they will heal better, or more welcome than the typical austere hospital room. And you'll never see me or any other pediatrician in a white coat unless asked for a photo op or meeting a donor or giving a very important speech. So there's a common phrase that all of us in pediatrics and child health always say: kids are not little adults. And that single idea is the reason pediatric research is not optional. It is essential, and essentially different from those serving adults. We all know this. Children are growing, developing, changing in ways that are biologically profound and distinct. Their brains are literally wiring themselves. Their immune systems are learning. Their organs are maturing. Even each vital sign in children, we need a reference chart. We're not nearly as cool as our adult folks who can just pick on a couple different ones. We've got all of these and more that we have to learn. And because of that, a medication that is safe for an adult may be ineffective in children or conversely harmful in a child. And any parent in the room who's tried to dose Tylenol at 2 a.m. knows how complicated it can be. You see that on our next slide. That's their parent-facing. So a disease that looks the same on the surface can behave very differently depending if it appears at age 2 months, 2 years, 12, 17, or even 70. And if we don't study children at every age and stage, we will leave them behind. So tonight we get to hear about the passion of a pediatrician to ensure that every child and family has food, at least enough to manage their child's illness. And we'll also get a window into how technology and AI, along with their adults, can help kids be kids, whether sick or well. We really need to take care of the children. We don't need adults acting like them too.
All right. Good evening, everybody. My name is Layla DeWitt. I'm a pediatric hospital medicine physician at Brenner Children's Hospital. I'm honored to be here as part of the kickoff for Celebrate Research. I'm also a relatively new food insecurity researcher with a focus on evaluating food insecurity in the inpatient space while children and their families are in the hospital. Today, I'm thrilled to speak with you about how the problem of food insecurity in the hospital came to be recognized and how through institutional research support and incredible mentorship, our food insecurity programs came to be. Oops. Thank you. And with that, I'm going to tell you a story. During the first holiday season of the pandemic, I was the hospitalist attending on service, and I was called down to the emergency department to admit a baby, a 6-week-old baby with respiratory distress who needed oxygen after catching RSV. The mother actually presented with both of her twins who both had RSV. One of the twins was actually well enough to go home, and so mom was able to find a babysitter for the other twin so that she could stay in the hospital with the sicker baby. And so we get this child admitted to the hospital on day 1. On day 2, I see that he's making progress on daily rounds. He looks a little bit better, but not quite well enough to come off the oxygen. And so he remained admitted, and mom never left the bedside. And then on day 3 of the admission, the nurse calls me very early in the morning, which is very abnormal. Usually they should be calling my residents and not me at 7 a.m. But they did, and it was okay. They called me and they said, "You've got to come on the unit. This mom is very upset." And so I ran over to the unit, and sure enough, everyone is angry. And mom is yelling, and she says, "I have to be discharged home today. We cannot stay another minute." And as I'm watching her sit there stressed, she says, "If I don't leave today, I'm going to lose my benefits for me and my twins." And I see her hands shaking a little bit, and I just kind of stop and ask her, "What have you had to eat today?" And she says, all she's had to eat for the last 3 days was goldfish. And she's talking about the free goldfish packets that we kept at nursing stations. This mom was exhausted, and she was hungry. And it clicked with me at that time that we're keeping families in the hospital, right, to be with their children at the bedside, and they're tired and they're hungry. At the time, only children could order meal trays in the hospital because they were the patients, and it was really up to the caregivers to kind of find and purchase food while they were there in the hospital. That can be kind of difficult to do in the hospital. It can be expensive, especially if you're already struggling financially. And so this family's experience is not unique at all. In fact, it reflects a larger systemic challenge that we just really weren't aware of at the hospital in the time. So I asked, can we start a food pantry? And within 36 hours, there are about $1,000 of donations from the pediatric department faculty to run this pantry, and you see it here, stocked with monthly Costco trips. A little less than 2 years later, you see our pediatric residents assembling items for the pantry and meal bags overnight. And then eventually we took our show on the road. Here you see our own Dr. Becca Palmer, pediatric researcher right there in the second row, as well as our department chair, Dr. Lindsay Thompson, and we assembled food bags and gun locks and took them to various community health fairs, and it went really well. But how did we make this research? This team of researchers you see here are really the reason that I got to get started and do this work. Doctors Callie Brown, Deepak Palakshapa, Joey Skelton, and Kimberly Montez are great friends of mine, and they're also great mentors. They are all health service researchers with expertise in food insecurity. And in discussing the pantry and food insecurity in the hospital, we realized we had a lot to learn about what families were experiencing, the fact that we weren't even screening them appropriately. And finally, we realized that if we get a better understanding of what food insecurity looks like in the hospital, perhaps we'll understand what impact that has on children when they leave. And so we received institutional pilot funding here from the Center for Prevention Sciences and Child and Family Health to study what inpatient food insecurity even was. Who was it affecting? Was the pantry even making a difference? We wanted to know, do the additional stressors of a hospitalization, like financial, personal, social, Do those change someone's food insecurity status in the hospital? And is there a difference between inpatient food insecurity, which you'll hear me call IFI, versus household food insecurity, or HFI? So we developed our own screening tool to measure IFI. We made this up. If you see, you'll see those items here. Each item starts with, during this hospitalization, have you eaten less, have you skipped meals, or have you felt hungry because you didn't have money for food? A yes to that question was a positive IFI screen for a caregiver for that hospitalization. So we collected that data along with household data over 18 months at Brenner's, and here's what we found. Of the 9,300 hospital encounters we covered, about 8% were positive for IFI, compared to 6% that had HFI or household food insecurity. We found that almost half of the caregivers with IFI didn't have household food insecurity. So if we had just screened them for household food insecurity in the hospital, we were going to miss a lot of families that were struggling with hunger in the hospital. We also took a closer look at these kids and adjusted for their age, sex, race, language, and insurance status, and we found that those kids whose parents had IFI were in the hospital about 2.5 days longer than kids who didn't. They also were 1.8 times more likely to be readmitted within 30 days compared to those without IFI. And both of those were statistically significant. And so this study helped us create a free meal tray program. So now we provide free hospital meals to any caregivers who are screened positive for food insecurity in the hospital. This led our team to find other sustainable ways to address food insecurity in the hospital, including federal nutrition programs like SNAP, the Supplemental Nutrition Assistance Program. You can see here that we know SNAP has positive impacts on child health outcomes. We know they miss less days of school. There are fewer ED visits for asthma exacerbations, improved birth outcomes. But enrolling in SNAP is difficult. You have to get transportation to get to DHHS downtown to fill out the application. You have to do an interview with a licensed DSS, Food and Nutrition Services worker. They have to get your signature in real time on the application. The application is pages long, so if English is not your first language, it is going to be very difficult to figure out. And these are all lots of reasons why North Carolina is actually in the top 5 for largest SNAP gaps in the country, representing those who are eligible for SNAP but not yet enrolled. And so if you look at what this looks like in North Carolina, we know in Forsyth County we have work to do. The food insecurity rate of children in Forsyth County is about 21%. It's higher than the state average of 19%. Same thing with SNAP eligible. 79% of our kids in Forsyth County are eligible for SNAP versus 73% in North Carolina as a state. So like I said, SNAP is great if you can get there to apply. And so our team thought, what if we brought SNAP to our patients in the hospital and in the clinic? We were awarded a $540,000 grant through the Duke Endowment to do just that. We developed a program to implement SNAP enrollment in our own clinical setting, which meant we were bringing DSS employees into the Children's Hospital, into the Downtown Health Plaza Pediatrics Clinic to enroll families on site. What did this look like? Well, first we had to start our own screening. Then we worked with our local Forsyth County DHHS team to help us identify and hire 2 SNAP employees, as well as onboarded 2 community health workers. And then we put a dyad of 1 DSS worker and 1 community health worker in the Children's Hospital and another dyad at the Pediatrics Clinic at the Downtown Health Plaza. And so they were there to capture families and enroll them as we saw them for a clinic visit or during their hospitalization. Since the beginning of this program, we've enrolled over 130 families in SNAP directly from their clinic visit. They never had to go downtown to DHHS to apply. And so here are some things that our patients have said after enrolling. There's so many obstacles to even think of to get to the offices of SNAP. I think it's really important work. It's beneficial to patients and their families. It helps overcome obstacles like transportation, maybe appointments, maybe if a parent can't get out of work. I think it helps with not having those barriers in place. Even the language was easy. They adapted to me and my needs because I only speak Spanish. So at the hospital with Spanish speaking, it was much better, it was faster, because it seems that they could help me with that more quickly. For SNAP, I'm able to provide food. That's one way I know for sure that I can help provide for the household, is being able to buy groceries this month, or buy groceries in the first couple weeks of the month. I'm able to provide with that for sure, so it's helped me and my baby's dad's stress level, because my baby's dad's stress level is he's a person who's bringing in all the money, really. We don't worry about that anymore. We don't have enough money for food, or I don't have anything to cook. Now I just take my card and I go buy food or the things that I need. But there's more work to do in understanding how interventions on food insecurity impact actual child health outcomes. Our team is also running a 3-arm clinical trial that you see here, the NOURISH trial. nurturing outreach for understanding and reducing inpatient security of health. Yes, we absolutely use an acronym generator to make this title, and I will admit that. In this feasibility study, we are evaluating interventions, including weekly family meal deliveries, grocery store gift cards, and we compare those to our standard of care, a paper printout packet of local food access resources to hand to families on discharge, and we follow them for 4 weeks. We are hoping to expand this trial to a much larger clinical trial that would allow us to really follow child health outcomes and other family health measures. We also plan to look at those key hospital metrics that we know can have a significant financial impact on the health system, like readmission rates at 30 days, like following up with their primary care doctor. I'm also really grateful to say we have wonderful partners in this work that include Second Harvest Food Bank, By Heart Infant Formula, and Aetna CVS, who really want to help us understand if interventions like this for hospitalized kids actually improve health outcomes. As far as future directions go, we are working to expand our SNAP work across the PLEADS clinical setting, really across our entire enterprise. And so we're working with our DHS colleagues in Mecklenburg County and Guilford County to try and bring this program to our other sister hospitals. We also feel that our feasibility trial has laid the foundation for an NIH-funded R01 application to test a scalable inpatient food as medicine intervention into a much larger randomized trial to really translate hospital-based social care into evidence-based pediatric practice. With that, I'm sure you're tired of hearing me talk about this, but I want to thank you for giving me the chance to talk about our team's work and highlight the importance of identifying and acting on inpatient food insecurity. I appreciate your time and the opportunity to be here. Thank you.
So thank you. My name is Joey Skelton. I'm Vice Chair of Research in the Department of Pediatrics, and I'll be shortly having our other guests introduce themselves here, but we're really glad that you all came tonight. When Lynn Wagenknecht chose me to do this, she says, whatever you do, don't start doing dad jokes. Nothing can stop a dad joke except a mom. So we have 3 researchers that happen to be moms, and now I know why they were, besides their great research, I know they were choosing to neutralize me. So well played, Lynn Wagenknecht, well played. So actually I'm gonna have my guests, because I will mess things up being a dad, I'll have our guests introduce themselves. Ellen?
Great. Hi, I'm Ellen McGinnis. I'm an assistant professor and a clinical child psychologist by training.
Hi, I'm Savi Nageswaran. I'm a professor and I'm a pediatric palliative care physician as well.
Hi, I'm Jill Urban. I'm an associate professor in the Department of Biomedical Engineering, and I do injury biomechanics research.
Yeah, so quite the interesting thing. And so one of the reasons, besides being moms, to neutralize me is all of you all do a lot of different types of research. You don't neatly fit into one sort of category, whether the methodologies that you use or the areas that you work and things like that. So I'll sort of start with Ellen. Like, what are the different things that you pull together? Because you really sort of undersold your research. You do a lot more than that. So tell us a little bit about your research and sort of the different areas that you sort of pull together to do this type of research.
Sure. I think I started out kind of as a basic researcher, some clinical research, and I focus on child mental health and trying to figure out ways of how to screen and intervene using some digital technology so that can be a scalable solution for kids. And I started out probably 10 years ago focused on basic research of understanding what happens to a child's body in terms of their movement and behaviors and physiology when they're stressed out or when they're experiencing joy. Those things that Dr. Thompson mentioned, that fear and the joy of childhood, what does that look like objectively? And then kind of moving on to understanding from clinical validation studies of how can we use some of that information to be able to gain information about kids and maybe step more with the clinician out of the loop, and how do we use that information to triage, because there's never going to be enough child psychologists or therapists in the country, in the globe. And so we need to figure out how to get to match kids with the highest needs with those providers. And so as a clinician, practicing therapist myself, I was kind of able to match or bridge that clinical need with the basic science. And so now, 10 years later, our team has figured out ways of how to get that objective data using wearable sensors on kids, how to understand that and match that with the parents' reporting of the child's anxiety and depression and ADHD symptoms. So how to understand more about that child and miss fewer kids when we try to identify those issues at primary care. And then how to personalize and match them with the right level of care. And some of that care can be digital technologies and through an app that can give the parent information. And so I think it was important to be a clinician to know the pain points. It was important to be a basic researcher to understand those validation studies that needed to happen. And I think bridging over time those two together and now understanding how to implement that possibly in primary care is what I've integrated.
That was a much better explanation. So, Savi, when I met you 18 years ago, you weren't doing this type of research. So kind of tell about the different things that you bring into your research.
Yeah, so I started as a clinician here, as a hospitalist also. And I wanted to do research in children with medical complexity, but didn't have much of a path. There was not a program for children with medical complexity here. So we started our clinical program. We started our palliative care program, again, got funding from the Duke Endowment. And then slowly, I just got introduced to other clinicians and many different stakeholders, both in the hospital and in the community, and slowly built our clinical program, and we started taking care of seriously ill children. Alongside, I always wanted to do research, found a lot of mentors, and some of them are now my co-investigators still, 20 years later. So slowly, initially I used national data sets, did using survey data sets. We kind of identified gaps in delivery of care for seriously ill children, and then got smaller grants, and then slowly built our program, research program as well. So I used different methodologies. One was the survey data analysis, but then branched into like network analysis, like quantitative data, did a lot of qualitative studies. And I will say that almost all of my research questions have come from patients or from people who work in my team who know what these families are experiencing. So that was early on, a community partner said respite care is an important gap, and so I studied respite care using the resources that I had. Then home health nursing, we interfaced directly with families who had challenges with home health nursing, and that took me to qualitative studies on home health nursing, and then that expanded to a randomized control trial on a new model of care to improve home health. So essentially, all my research has started with my clinical experience or directly hearing from other clinicians and stakeholders. And then we similarly, during COVID, we saw children who are medically complex have difficulty accessing specialty services because of the shutdown, but then also learned that telehealth was an important part of the care. And then we built on that, did qualitative studies, and found out that telehealth had a role not only in during COVID, but also outside of that, because it's incredibly difficult to bring a child who is medically complex to clinic appointments. So we got all the qualitative data from our CTSI pilot grant, and then I used that to get a larger grant from the Patient-Centered Outcomes Research Institute, and we are now studying a new model of care telehealth for medically fragile children and testing how that is going to improve the health outcomes. So.
And Jill, I grew up in Northeast Tennessee near Bristol Raceway, so my redneck side says, I know you do research with NASCAR, but I know that's not all you do. So if you want to tell a little bit about your broader research besides that.
Yeah, so our broader research is really focused on using wearable sensors to study head acceleration event in sports. And we work across the age spectrum from youth all the way to adults. My primary research is focused on youth tackle football, a space that we've worked in since 2012. We've been working with the community for almost 15 years now. And early on, our research that was led by our colleagues, Dr. Joel Stitzel and some previous colleagues in radiology, we were looking at the effects of head impacts on the brain, looking at the cumulative exposure to head impacts and how that related to changes in brain imaging and cognition. And I found myself as a student at the time really interested in how we could use the biomechanics data to help improve sports safety. And so as an early career faculty member, I received an internal grant from the CTSI, our KL2 award, and that allowed me to get a master's of public health. And I think as an engineer, it's not very common for us to adventure out into public health, but I loved it. I learned so much about engaging the community and how we could really work with the community to develop practical and actionable strategies that could actually improve sports safety. And so under the mentorship of many folks in the institution, I developed a K award through the NIH that was focused on developing and evaluating an intervention to reduce head impacts and concussion risk using a community-engaged approach. And so a lot of what we do is work directly with parents, coaches, and organizational leaders to understand what they need, what are their concerns around safety, and how can we use the biomechanics data that we collect to help inform practical strategies to improve sports safety. And from that, we developed an intervention program called COACH, Communities Aligned to Reduce Concussion and Head Impact Exposure. And now we have an R01 to do a stepped wedge trial to evaluate the effectiveness of that intervention program. But everything that we do is grounded in working with the community to achieve our research goals.
Did you use the generator like Layla did for the name, or did you all come up with that?
No, we actually came up with that on our own.
And none of my peers in community engaged research think you're real, because like an engineer is doing community engaged research, like yes, and she's quite killing it. So, Sabi, I want you, and I think this is very important for PEDS research. The NICHD, the government funding focused on PEDS research is a very small amount. We always tend to joke of, they tend to do funding for PEDS research by weight. So they do give us very much lower money. You've had a broad array of funding from fundraising to foundations to PCORI to NIH. If you could sort of speak a little bit about that.
Yeah, so no grant is small, and it's always worth showing up or submitting a grant. So my first project, I think the range has been $1,000 all the way to $4.5 million. So one of the first ones was from the American Academy of Pediatrics, had a CATCH grant. It's a community grant. So got $10,000 for children with special health care needs, creating a curriculum for residents to do a home visit program or learning from community experiences. So I used that then to get a grant from Health Resources and Services Agency, which is a federal agency under DHHS. And then I've had multiple grants from, it's called HRSA, for community-based care coordination programs. I've had grants from 2009 until I still have a grant from them. So initially we started with a care coordination program for children with medically complex children in Forsyth County, used the exact same model to other rural counties, and then the same model to Guilford and Randolph County. So slowly built it over a 10-year period to different counties surrounding Forsyth. So that was one path. And then slowly our children started growing with us, and now we got another HRSA grant to transition them from pediatric to adult care. So each grant then led to the next one, and then I got the home health nursing study was from a National Palliative Care Research Center, and it's a small qualitative study, and then that then led to like 6 or 7 papers and another grant on home health nursing model also from HRSA, and then same thing with a small grant then leading to a bigger grant. So I think I've had a very good success from all different agencies, but also have a lot of grants that have not been funded. So showing up, writing the grant, and then waiting to see how things go. Going with the flow is the way to go.
And with our dean and my chairman here, funding is a very serious issue. And so, Ellen, I have a very serious question for you. My wife and I can't be in the same room to load the dishwasher. We fight too much about it. You do research with your husband. Like, how do you make that happen? Because I need to learn how to do this. So.
Well, carefully, I would say. We started in grad school. Dr. Ryan McGinnis, my husband, is the director for the Center for Remote Health Monitoring here, and he is a biomedical engineer. And so he was doing something way less valuable with his time, which was putting wearable sensors in baseballs and studying
Jill's
pitching.
very upset when you're speaking right now, okay? Just know she's getting a little defensive for your husband. So.
And I came to the rescue and said, we need to save children. This is way more important. And so I was video recording, 100 kids 5 to 10 years old in a lab in a dark closet, just coding their behaviors. Like, oh, they stepped back a half a step. And I was like, this is not that fun either. But we decided in graduate school to put his wearable sensors from a baseball onto the waist belts for these kids. And I realized, wow, this takes away all of my coding needs and training an army of undergraduates that I didn't have to do in 3 years of coding. And we can get this data wirelessly, immediate, and reliably. And it really told us a lot about child behavior in a way that hadn't been done before in the field. So we were the first people to put wearables on kids for mental health reasons. And so that was in 2011 when we started graduate school. And so we've been working ever since kind of doing more clinical validation studies with wearables in kids in the field of mental health.
So exactly like loading a dishwasher is what you're saying, okay. We've grown a lot. Our research enterprise has grown a lot over the past couple of years. So I've been, they call it the recruitment way game, where you're going to dinners and stuff like that all the time. And one thing I can never articulate very well is I just say we just have this weight culture when it comes to research. And I try to find all these different ways to say it. I do research with probably 5 or 6 different departments, multiple different disciplines. It's just easier to work with people here. And I want to hear a little bit about, for your all's experience, we'll start with Jill, of just like, that's how we met, was you were an engineer trying to do, and I thought it was a mistake, you're getting a community consultation. But what is about the weight culture that's helped with your success?
Yeah, I've really been fortunate to have great mentors that have been willing to take me under their wing. And my primary research mentors focus on cancer prevention and weight loss and obesity prevention in kids. And so doing sports injury prevention is sort of a different area, like not their areas of expertise, but they know so much about implementation science and community engagement, and they've been so kind to point me in the direction of resources within the institution, connect me with collaborators, and say, hey, I don't know the answer to this, but you should reach out to this person. They're a great resource. Connecting me with the program for community engagement. And I think just a willingness to share knowledge and see young faculty grow has just been really remarkable in my interactions within the organization.
And Savi, you're not only with other faculty, but with staff and community. You obviously, that weight culture permeates to not just the faculty side, but to the research side and the clinical side and things like that.
Yeah, so this is a very collaborative environment here. So that's what makes this very unique. And so as I said, some of my mentors are still my collaborators, and that doesn't happen very often, and I'm so grateful for that. And also the same thing extends to our community as well. There are many community partners that I started working with 20 years ago. They are still partners, and so the whole environment, both within our institution and our community, is a very collaborative environment. And we have all the resources that we need here. And I have seen in the last 20 years all those resources expand and grow. So it's a really great time to do research here at Wake Forest.
Ellen, what about you?
Yeah, I would say there's an expert for every possible thing that you might need help with along the way, especially if you focus, on one research problem to solve, whether it's child mental health screening. At first that might be okay having basic science training, but along the way, if you want to follow this problem all the way through to a solution in primary care, you need to learn so much along the way about, clinical randomized control trials and about implementation science, which I didn't have the training for. And it's amazing here, you just, look, there's an entire department of implementation science, and you just email a person and everyone wants to help you. So I don't think you could continue across the continuum of translational science without the collaborative environment that we have here.
And I'm seeing it now with, we call it the other campuses, but our Midwest partners, our Charlotte partners, and being able to extend that and them getting in, and they have a lot of that friendly culture too, that I've really enjoyed. Cheryl Lefevre, if you're listening, I'm looking at you. But I think that culture is spreading even broader with that. Jill, as an engineer, how do you load a dishwasher? No, I'm just kidding. So, Lynn Wagenknecht, 3 dad jokes. Okay. So, and y'all have all touched on this a little bit, is, what advice would you give, not only to an early stage researcher, but also to someone that may not see themselves as a researcher? Now, Layla talked a little bit about kind of coming into this, sort of accidentally, and we learned that she did really good work, so we kept giving her more work. But so what would you tell others, that are new to research, and what would you tell them about getting started, given the success that you all had?
I can start with that one. I mean, I would encourage new folks to ask the question. If you're curious about something, ask the question and just start having conversations about that research area, because you never know who you're going to meet and who's going to help point you in the direction of a collaboration. And another piece of advice is to be persistent and resilient, because you're going to find a lot of roadblocks early on, and it doesn't always work out perfectly. And when we present things, we've got beautiful graphs and it looks wonderfully, and we tell you all about the funded research, but there's a lot of bumps along the way, and you really have to persist through those.
Ellen, what would you say?
I got an NSF I-Corps grant a number of years ago, and that is all focused on entrepreneurship and teaching researchers entrepreneurship.
Savi, that's the only place you've not gotten money from, I think. So.
And it really transformed how I do research. And what their process is basically go out and interview people. I interviewed over 200 parents, teachers, therapists, and primary care physicians, and owners of digital health technology companies. And it's nice because they answer your emails because you're an NSF learner researcher. So just being able to speak with that many people and attack a problem from all these different perspectives was so important. And it really teaches you to follow these clinical pain points and understand it from multiple perspectives before jumping into something, because now I'm into this program that is, 10 years long of wanting to change child mental health, and you need that foundation that only stands on the shoulders of all these people who have been in it for so many years.
Savi?
So I would say you have to listen deeply to everybody, patients, if you're a clinician, to families, and also to your co-investigators, and really try to understand what they are saying, and then use that information to develop your research. Because there's no control over how the funding climate, all of that, but what you can do is actually really listen deeply, show up, and do the work. So that would be my advice.
Listen deeply. I would have expected Ellen to say that as the psychologist, not you. So it shows the multidisciplinary nature of our research. There's the parable of the blind men that are touching different parts of the elephant and describing that. So I want your all's view from where you're doing research right now of what you would see the future of where's pediatric research going. And that could be again in your area. For our area in the Center for Prevention Science of Child and Family Health, we want to look more broadly at the family. There's a lot of aspects about the family that we don't think about, and we're trying to get more people to look at that. And so, Ellen, where, at least from your area, where's a lot of research going, whether that's what you're doing or where you see the field going?
Sure, I would say specifically...
And you can't say wearables, okay? So, no, you can't, okay, sorry.
Well, maybe in the field of wearables. If we want to understand prevention science for children, right? I think a path towards that is continuous monitoring in between clinical visits to understand what's going on, tap into a little bit of what's happening with the family at home in between visits. And to do that effectively, we really need the tools to do so, because kids aren't little adults and wrist wearables don't fit the wrists and step counts child step counts. And so we need a lot of clinical validation studies and understanding user-centered design of these devices just to do the basic research to know like what is normative for a child versus a child with anxiety. And so I think that is a big piece. And I think just doubling down on prevention science and what's going on with the whole family, because especially in child mental health, a child's mental health does not live solely within their body. They have caregivers and coaches and teachers that are all a part of this world that they're in, and we need to understand the context of which they live too. And it's hard because that's a lot of extra burden to be surveying all these people and trying to get objective data from all of these people. And so I think first we need to build some systems and tools to get that data in the first place and then try to understand it.
Savi.
So for all these years, my work has been on trying to find gaps or describe gaps in the system of care for medically complex children. Now I'm in a state where I am thinking about intervention studies. How do you improve healthcare delivery? So the first study was the randomized trial about a model of home healthcare delivery. So that was only at Brenner Children's Hospital. And now with the PCORI project, we expanded that to Living Children's and us. So that's a fantastic opportunity that now we have, because we don't have that many children who are medically complex within Brenner alone. So that's a second study that I'm doing. But my goal is now we got a grant from the Center for Prevention Science to study the health of caregivers. My hope is in the future submit a advocate-wide clinical trial to study an intervention to improve the health of caregivers of medically complex children. So with the pilot grant, we are already partnering with all the 4 children's hospitals, and so we want to be in a good position to be able to submit another large trial to do an intervention all over our enterprise. So that's my goal. My goal is to expand or do clinical trials throughout our enterprise.
Yeah, in the field of sports injury prevention, I think we've learned a lot about male contact and collision sports, but there's a lot we don't know about the female athlete, and there's opportunities to learn about prevention. The targets might be different for female athletes. Concussion diagnosis and treatment might be different for female athletes. So I think there's a great opportunity to look at sex-matched sports and to also understand differences between males and females across different contact and collision sports. And the other space is really on prevention. I mean, a lot of our research has been on characterizing exposure, describing the types of events that athletes are exposed to, but there haven't been a lot of intervention studies, and we focused a lot on equipment, making helmets safer, making equipment safer, but at the end of the day, it's really a behavioral issue, I believe. And I think we can further improve equipment, but there's a lot about the actual play environment and what kids are doing when they're engaged in just normal participation in their sport that are low-hanging fruit and opportunities for prevention and reducing head acceleration events, those non-concussive events, but also concussions and other injuries in sport.
And I think for many that don't know, with our advocate footprint, there's some estimates that we will touch as many as 5% of kids in the U.S. So, and that doesn't mean the adults don't, but I think we really have, when it comes to the idea of prevention, and our reach with our advocate enterprise is quite immense, and it's a lot of pressure. You know, I think we've all learned from each other, and I look at Savi a lot of time, I'm teasing her about it, but all the different groups that you've gone for funding, like you said, you know, no grant is, you know, would you say no grant is small? I mean, you know, because it gives you data and it gives you that next step, and I think each one of you all have given an example of taking small things and turning in something bigger, reaching outside your comfort area, which I think, again, really speaks to the Wake Forest culture of it's so easy to call, or as someone said, we return emails most of the time, and you know we return the call, and you know someone that knows, and it's to me it's been a lot of fun, and I'm sure with you guys, I've talked with you all about this too, of making those connections to you know, across North Carolina to the Midwest, one of my sort of home states of Wisconsin, and having folks up there that you can work with, and so I think That'd be a big message that we want for everyone to know of just how big of a footprint we have, the opportunity we have, and how doing that together through all the resources that we have, as well as others, through our philanthropy office and things like that, to really achieve that. Any final words that you would share with the audience, both here as well as virtually? It doesn't have to be about loading dishwashers. I want to ask about the most famous NASCAR person you've met, but that's probably protected or anything, so.
I think we have a tremendous opportunity to advance pediatric research. So I think making use of the resources that we have and doing the hard work is actually not only for what we should do, but we have an obligation to do that. That's how I see it at this point, because we have the resources. Now we have the study population. So we should be doing the research and advancing pediatric research.
And I think all of us up here use technologies in studying pediatrics, and I think that offers opportunities to have this to be extremely scalable and reach all of these kind of satellite clinics that we have in rural populations. And that's really exciting because, like you said, sometimes peds gets overlooked a little bit in grant opportunities, and being able to show that we can reach 5% of all children in the US is a heck of a hook statement in your grant.
And the last thing, I would love to acknowledge all of our students and our learners that support our research. I would not be here if it wasn't for the graduate students that support our research, and we really are training the next generation of researchers, and they support so much of what we do. So I just love being able to share our research with them and help them grow pediatric research as well.
You're not saying that because my son was in your lab.
He was great.
But also you see the effect of the pilot grants that are going on at Wake Forest and are now spreading across enterprise. And there's more going straight to peds, which we're really excited about. And yes, we play a drinking game every time the McGinnises say wearables. You're supposed to learn, so that's all right. So thank you all. Please give them a round of applause. And I believe, if I remember the thing right, is we now have a video presentation for you guys.
Bonjour, hola, good evening. Me llamo Romeo Modave y tengo 7 años. J'aime les cartes Pokémon, Harry Potter et jouer au foot. Et écouter de la musique avec mon papa dans la voiture. También me gusta aprender sobre los países del mundo. ¿Sabéis que la capital de Mongolia es Ulaanbaatar? Mon papa François Modave est super cool. Il travaille très dur pour aider beaucoup de gens grâce à l'intelligence artificielle pour la santé. A veces cuando él está trabajando, yo le digo, papá, ¿puedes venir a jugar fútbol? Mais aujourd'hui, c'est moi qui va présenter. Voici mon papa, le docteur Modave. Il est très gentil. Il sait presque autant sur moi, sur les capitales du monde. Vamos, papa!
I'm just going to stop here because I can't beat that. I'm very, very biased. I'm going to talk about biased data actually today. Thank you, Romeo. Thank you. I'm just going to start prefacing my talk saying that I feel like an imposter today because I'm not a pediatrician. I'm not a physician. I don't care. I don't provide care for patients. But what I try to do is I try to build useful AI tools or assess useful AI tools that can be used in clinical practice. And that's what I would like to talk about today. So I want to talk about something that touches all of us, which is the health of children. And I want to explore how AI might impact pediatric care and where there is still a great deal of work to do. The title of the talk is bold. AI will change how we care for our children, and I believe that's true. But I want to be careful with that framing because change does not automatically equate to progress. And the question that should drive us is not whether AI will transform pediatric medicine, but whether we can ensure that that transformation is safe and equitable and genuinely beneficial to all the children. So to understand why AI is attracting so much attention in this space, we must start with the real pressure that pediatric medicine is facing. Physicians spend on average about half their day working on documentation. Specialist shortages are severe. For instance, there are about 300 pediatric rheumatologists that care for millions of children in the US, and the wait times can be over 2 months, which is oftentimes not acceptable. Additionally, in our NICU, for instance, critically ill newborns generate thousands of next slide. Thousands of data points per hour, and that's far beyond what any care team can analyze in real time, and so we need to leverage AI to do this. So these are genuine serious problems, and it's precisely because they are serious that we need to be very rigorous about the tools that we deploy and how we address them. One of the most discussed applications of AI is in clinical setting is ambient documentation. Essentially, a AI tool that allows you to eavesdrop on the discussion and to essentially document the clinical visit and summarize the clinical visit at the same time, which allows. Are the slides moving at the same time? Okay. All right. My apologies for this. It's moving along. Is it possible to stop this? Can we have an AI thing stop this? All right, I'll try to do my best with whatever I can see. So the physician actually gets to spend the time looking at the patient rather than actually looking at the screen. For an additional feature of AI is that AI generate plain language summaries that can be very useful for families. Oftentimes you'll leave the visit thinking, what did they say? What do I have to do? And so AI provides those summaries that allow you to understand what was said. It's still moving forward. I think it's ironic that it's happening for AI stuff, but anyway. For health system, the impact is measurable. It means fewer transcription errors, better coding accuracy, reduced clinician burnout, and real return on investment. And the early data published shows that on average, you save about 72 minutes per day per physician, which gives over an hour back to the patients. But we should be very clear about the limitations. These tools are trained oftentimes on large bodies of clinical text that may not fully reflect the diversity of the patient population that we have. Additionally, there are errors that are generated by AI tools, and sometimes those errors can be very subtle, and so we need to be very careful with how those errors are assessed before we can provide summaries to the physicians or to the families. Trying to see where I am with this. So perhaps the most compelling potential of AI in pediatrics is the ability to help bridge the specialist access gap. Triage algorithms that analyze data, labs data, symptoms, and clinical notes have the potential to identify conditions early for things like juvenile idiopathic arthritis or lupus, and represent a genuinely exciting direction, one that could potentially get the right child to the right expert months sooner than current pathways allow. I'm still at the right slide, so that's good. Another advantage of using AI tools is that it provides automatic ways to create smart referral routing for young patients, as well as virtual pre-assessment tools that save time during clinic visits. And finally, we can leverage AI to create population health dashboards that identify undiagnosed patients, or kids, by careful examination of the many variables in electronic health record systems. And so we have very thoughtful applications with real logic behind them. But once again, the algorithmic triage, etc., is only as good as the data it was trained on. If these data underrepresents children from, for instance, rural communities, from lower income households, from racial and ethnic minorities, and historically clinical data has underrepresented those populations, then the AI triage tool can systematically deprioritize the very children who already face the greatest barriers to care. So that is not a theoretical concern, it's a documented pattern in AI health tools. And so we need to actively work on those questions so that this is carefully addressed. So the goal is really to get the right child to the right expert at the right time in our health system. Oh, now it's moving, okay. The last application is related to the NICU. So that's a very clear case of where AI can help, because we have all those data flows of that are coming in real time with thousands of data. And so in this case, a premature infant's condition can change in minutes, and AI systems allow you to very continuously analyze the data, potentially analyzing flagging deterioration hours before it becomes clinically apparent, and could meaningfully support care teams under extraordinary cognitive load. An additional example is with respect to sepsis. We know that we can identify sepsis very neatly with AI tools. It does not always address the question of what do we do once it's identified, but we have ways to identify sepsis possibly a lot earlier than otherwise. Feeding and growth algorithms offer another possibility for AI, where we can actually build more personalized medicine for newborns and more personalized nutrition so that they have a nutrition that's ideally suited for them. And then the last example is smart alarm filtering, which aims to reduce the false alarm burden that contributes to alarm fatigue, which is one of the highest safety risks cited in neonatal care. So those are real advances that are worth pursuing, but NICU also illustrates why rigor matters enormously. False negatives from a deterioration detection algorithm or missed alert carries consequences that could be extremely serious in newborns. A false positive float can erode the trust that clinicians place in a system, causing them to discount the alerts over time. And then the feeding algorithms that perform well on average may not perform well for a specific infant with a very specific clinical history. So the question is not whether these tools have the potential, they do. The question is, how do we validate them? How do we monitor them in real-world conditions and maintain meaningful human oversight, particularly in an environment that's high stakes like the NICU. So I'd like to end the talk with a question about, should we trust AI, especially with our children? I think it's the most important question, and I want to be very direct about the answer. Every AI-generated note or alert or referral is reviewed by a licensed clinician before it affects a child's care. We validate algorithms across race and geography, insurance status, and language, because bias in a data set will lead to bias in an outcome, and we cannot accept this. So AI build here operates with very rigorous frameworks, pre-deployment vetting, real-world surveillance, and continuous performance monitoring. So it is really a living clinical tool that is held to a living standard. So I'd like to finish saying that the vision is, I think, worth pursuing, otherwise I wouldn't be here. Advocate Health, Wake Forest University School of Medicine, beyond the tools, we're investing in the governance, the validation, and the clinical framework that make responsible AI deployment possible. We're not moving fast and assuming that the science will catch up. We're doing the work because that is what our patients deserve. So I think AI holds genuine promises for pediatric care. Getting there requires honesty about what we don't yet know, requires humility about the limits of early evidence, and a real unwavering commitment to the children and the families at the center of it all. And I will say thank you, and I'm happy to take any question afterwards, or by email, or text, or whatever.
Francois thought that he was the one that was keeping you between any food and walking around, but that's actually me. So I just really want to thank all the presenters tonight. It really was informative, exciting, and the future for pediatric research is just wide open. And as you heard from these presentations, pediatric research asks questions that nobody else can. So how does early life shape lifelong health? Or why do some conditions like cardiovascular disease begin in childhood but don't show their full impact or measurability until adulthood? And vice versa. Why are some diseases like lupus, we've actually heard a lot about rheumatology tonight, why is it so much worse in children? And how do families, schools, neighborhoods, and technology influence health in ways that no single prescription could? And this is why pediatric research looks different. It must be developmentally informed, it must be family-centered, it must be ethically rigorous, because children rely on us to advocate for them. It is my why. So this is the coffee mug that I keep in my office. It was given to me by 2 mentees, and it keeps me focused on that bottom line. And actually, I just don't want them alive, I want them to thrive. And it also reminds me of the joy I get from teaching. Because pediatric research is incredibly hopeful. When we invest in children, the return is measured not just in months and years, but in decades of possibility. So research that improves asthma care in childhood, reduces adult lung disease, research that supports healthy nutrition and activity in kids, changes the trajectory of heart disease and diabetes. Research that improves mental health care can alter the entire story of a whole family. And like you've heard, despite this excitement, pediatric research often receives less attention, less funding, and less visibility than adult research. Children don't vote and they don't write grants, although Savi might get them to. So research has been hampered by the simple problems of relatively rare disease and rare adverse outcomes. So that means it's our responsibility and our opportunity to speak for them. Engaging people in pediatric research actually doesn't require a deep science background. It requires curiosity. It requires asking, what would it take for every child to have the healthiest possible start? What would that look like? It requires recognizing that breakthroughs don't only happen in laboratories, they're extremely important, but they also happen in clinics, in communities, in classrooms, and in kitchens with their families wrapped around them. It happens where they live, thrive, and play. So here at Brenner, at the School of Medicine, at the Baptist, at Atrium Health, and yes, at Advocate. So we're trying to do just that. Dr. Skelton talked about the fact that we believe we cover 2 to 5% of US children in our footprint. We have 1.5% of US births born in our hospitals. That's where our children are growing. So this creates a real obligation for us to improve the care we provide to them. You've heard that a few times tonight. When we study children, we're not just treating disease, we are shaping futures. So when you hear the phrase, kids aren't little adults, I invite you to hear it as a call to action. It's a reminder that children deserve innovation built specifically for them, that their differences matter, and that pediatric research is one of the most powerful ways we can invest in a healthier, more equitable world. Because when we get it right for children, we get it right for everyone. So, say it with me, I'm gonna make you. Kids are not little adults.